Hi, everyone. I'm Margaret Malone. I'm an investor at Flair Capital. We are an early-stage healthcare-focused venture capital firm, and I'm also on the board at Dime. It's truly a pleasure to be here today. What an awesome audience, and just huge shout-out to Jen and the entire Dime team for putting this together. So thank you again. Woo! Yeah. So I will try not to speak that much, but I do want to set the stage for this discussion. It's a super important one, reimbursement. How do we actually pay for the innovation we've been talking about today and we'll be talking about this afternoon? So in order to execute on the vision of Healthcare 2030, we must come together as a group to kind of build and ideate around what a system should look like that is financially viable. And that includes all parties, and reimbursement, as I said, is kind of critical to that. In this discussion, we'll cover a lot of topics, what needs to change, what needs to evolve to meet those goals, what the role of each of us will play in that vision, what evidence is needed, and much more. So with that, I will hand it over to each of the panelists. If you guys could do kind of a quick introduction, that'd be great.
Hi there. So Mona Siddiqui, I lead home and community care for Highmark. Just by way of background, Highmark is a $30 billion integrated healthcare company. So we have our insurance side of the house. We also own Allegheny Health Network and a robust set of assets in the post-acute side. I run our we have home medical equipment, home infusion, home health, hospice, and home palliative, a risk revenue business, as well as our post-acute network management assets. Prior to this, I was at Humana. Relevant for this conversation because 3 years I was on the insurance side of the house, leading everything related to total cost of care for MA, Medicaid, and commercial.
Hi, everybody. Jonathan Taylor. I'm Vice President with Aon. For those that you don't know, Aon is a top 3 global consulting firm. I specifically work with employers on their people risk, and more specifically, that's with health insurance plans and employee benefits.
And I'm Nate Paulsen. I am VP of Health Plan Partnerships at Oshi Health. We are a virtual gastroenterology multidisciplinary clinic. We do medical care, so we can diagnose, prescribe, et cetera, with the care journey, but we also surround that medical care with dietary and behavioral health that follows evidence-based guidelines. Prior to Oshi, I led care innovation strategy at United Healthcare, where I designed payment models specifically for different care models across the spectrum of care. And so I had the pleasure of working with Oshi on that side and designing a model that was specific to the care they were delivering and the outcomes we were seeing from their care model. And now I work with other health plans to kind of bring that to scale.
Yes, and I'm Fleisher. I always start, I'm a practicing anesthesiologist, although only twice a month, and a health services researcher, but of relevancy, I was the Chief Medical Officer and Director of the Center for Clinical Standards and Quality during the pandemic from 2020 to 2023, so reporting directly to the administrator of CMS. Since then, I founded an advising firm with my son, but I also advise on policy through the Bipartisan Policy Center, Duke Margolis, and the Milken Institute.
Awesome. So let's jump right in. We'll start with a little bit of an icebreaker just to get the conversation going. So if you could change one incentive, policy, or payment model to make the system more sustainable by 2030, what would it be and why? And Lee, I will start with you.
Make models mandatory.
Can you say more?
Yes. So as I will probably talk about, the problem with all the models from CMMI for the last, since the ACA was enacted, was that they are voluntary. So when I was at Penn Med, which I still practice at Penn Med, but I was the chair of anesthesia and ran managed care contracting, we would know the data and we would only join models in which we would win, because we were a big center that could calculate that, and never join models in which we would lose. And if you can game the system that way, you're never going to get to value-based care, as we call it, and therefore you need to mandate that people be in the models, which is actually what the current administration is doing.
Yeah, so I'd say mine would be disconnecting commercial insurance from medical loss ratio. When your profitability is tied to 15 cents on the dollar, the fastest way to grow your profitability is to grow the number of dollars spent. And so changing that incentive and disconnecting that, I think, is really critical to changing the incentives around how we spend and purchase care.
That was good. So a lot of what I'll talk about is from the consumer standpoint. Simply put, we need better cost transparency for the consumer. If I picked out seven of you right now, and I said, you have Blue Cross, you have Cigna, you have Aetna, you have whoever, you have Medicare, and you go to a provider for the exact same thing, every single person's gonna have a different price. Not to mention if you don't have insurance. So in a system where we access healthcare through insurance, we need to have a way of defining what cost is and making this easier for the consumer to understand and use.
Nothing that I would disagree with so far. Maybe just sticking to where I focus daily, which is care in the home right now. How many folks are familiar with care in the home or models for care in the home? Okay, so a good group. I will say when I started to enter the space, it was the first time I had any exposure to care in the home, and I realized it is even more heavily regulated than the rest of healthcare, which is deeply frustrating. Obviously, we have an aging population that is coming our way, and the regulations around who can go into the home to do what, for whom, and across different states, I think really is a hindrance to being able to provide good care that is outcomes oriented and scalable. So I do think that we need to re-examine some of the regulations around the heavy burden of documentation and regulations around who can do what exactly in the home, because that is a real hindrance to providing appropriate care.
Having stood up Hospital at Home in 7 days in November 2020, the problem was program integrity and making sure that it didn't cost more for the country to deliver the same amount of care. So one of the things that would be great for the audience to think about, and for all of us who do policy work, is how do we achieve your goal while ensuring that we're getting the right amount of quality for our money?
I think that's actually like a nice, segue to our first question, which is how do we actually go from pilot to scale? And, in order to kind of innovate and achieve our goals of healthcare 2030, that's going to be pretty critical. So I'm curious, and maybe Nate, I'll pick on you here, since we're missing one of our panelists here who's going to tackle this. But I'm curious to hear your perspective. Who do you think are the actors that really are best positioned to help move us from pilot to scale?
Yeah, and I have a bias probably because of my background, but as we say in this talk, it's follow the money, and all money flows to and through the payer, whether that's CMS funds, whether that's employer funds, state funds, it all goes through the payer. And so as we think about scaling, it really revolves around, does the payer have the incentive to continue to incentivize cost savings? At the end of the day, a lot of that's driven by the provider and delegating risk to the provider. In a lot of cases, does that payer have an incentive to invest in payment models that incentivize better outcomes for patients? We've talked a lot about data, and we talk about data management is expensive, it's challenging, AI is bringing down that curve, but we haven't historically, we have CAP scores, but those aren't really tied to patient-reported outcomes of, do I actually feel better? It's tied to, did I have a good experience at the doctor? And how do we start to try and put more investment in tying outcomes of reduction in utilization, reduction in cost, better to outcomes of, I feel better, I have better control over my life, I'm not experiencing these symptoms, and putting those together to support value-based care. And I think that really comes down to CMS setting guidelines and structures and reporting metrics that aren't just utilization based. Incentivizing health plans to really at every stage be reducing the cost of care and not just through prior auths, and models for health plans to continue to empower and incentivize providers to be able to measure the right things and be accountable for the cost, as well as benefit and be rewarded for the outcomes.
Lee, I feel like you wanted to maybe chime in on that.
My only question is, you talk about measuring the outcomes, and I'll ask, HEDIS has been measured previously. I actually heard someone recently comment it's the best of the worst. How many people think HEDIS is a good measure of whether or not you're getting good health care? How many think it's the best of the worst? How many think it's bad? A couple. I think that's one of the things. We don't have a good measure of health that we can say people are getting good outcomes. We have what we can measure, which is a lot of, did somebody get mammography screening? Important, but does that measure how you're getting overall care?
I know we want to keep moving on. Colorectal cancer screening. It's one of the deadliest forms of cancer and the most preventable forms of cancer. And the only thing we've historically measured is, did someone get their colorectal cancer screening? Did they do a FIT kit? Did they do Cologuard? Did they get their colonoscopy? But 50% of FIT kit and Cologuard tests that come back abnormal have no follow-up care, because the insurance company, having worked in HEDIS and STARS, makes money off closing that gap of care, and that patient has moved on to another insurance company in 1 to 2 years when we just think about the turnover. And so, like, to your point, like, they're important measures. We need to be knowing, are we closing those gaps? But where's that financial incentive that says that preventive care is going to turn into outcomes? Or are we just telling people, hey, we're going to pay you more if you diagnose diabetic retinopathy? But are those patients actually getting better?
If we move on, Mona or Jonathan, do you have anything to add here? Okay, keep it going, I love it. I think we will I would be curious to kind of hear from the employer's perspective. What is the role of employers in this equation, and knowing US Americans, 50% of us do get our healthcare through our employer. Curious to hear your perspective there, Jonathan.
So this is really important. First off, yes, 50% of Americans roughly are accessing the system through insurance provided by their employer. Let's take Medicare out of it. Take anybody 65 and up out of the equation. The vast majority are accessing the system through the employer. So everything that I say today is going to be from the perspective of the end user. This is the struggle. This is why I have a job. I advise HR executives all day long on what to do. Couple of other, well, let me get right into it. So 3 things that I think that employers can do. Number 1, they've got to continue to incentivize personal accountability. This is something we've been talking about for years. I've been doing this for a long time, well over 20 years. We talk about this, but in actual practice, what that means is to incentivize an employee is still not really happening at the level that we need to see. The populations are full of what I call ghosts. There's a bunch of people on the insurance plan, that never access the system until there is a major acute issue or an emergency. That is a problem. So that gets into, obviously, PCPs, prevention, all of that. Number 2, that takes us right into health transformation is vital. The employers need to lean in even further into the plan designs that they have, especially the larger employers that are self-funded. They've got to have a game plan and not just react to the cost increases and whatever the insurance company says or whatever the market says. They've got to have a plan to incentivize and drive health behaviors, providing steerage to best-in-class care. This is very important. Number 3, HR needs to be empowered to run a business. This is the second largest expenditure for any company behind payroll. Healthcare trend in America, and I'm going to really lean in on this one, I get very passionate about this. Healthcare trend in America is at 10%. Healthcare trend in America is at 10%. That doesn't mean your insurance premium went up 10%. That means just cost of care is going up 10%. Then you've got administration, then you've got this, then you've got that. Insurance companies have to make a profit. You have employers getting 12, 15, 20, 40% increases to their insurance. Imagine a scenario where every year employers had to increase payroll, people's pay at a 10% clip. That's absurd. We would never do that. We can't do that. But yet the second biggest line item for a business owner or an executive team running a company is healthcare. That's got a downstream effect. Here are your options when you have that. Number one option is you say, hey, here's your 3% increase. Great job last year. We're increasing your insurance premiums 10%, 12%, 15%. How many people quit over that? Or your next option is to say, we can't, and this is what happens most of the time, we can't do that. We're going to absorb it. We'll pass on a 5% increase, still have the exact same noise. Our increase went from 10% to 12% or 15%. So then that goes downstream to what do you do for your business? You've just had to increase your product cost. This is unsustainable for the US economy. So going back to what I said, it is vital that HR stop reacting to this as just a deal with the renewal and move on. They've got to run a business for the business. And why this is just absolutely critical, I'll leave you with this fact. The average cost in America for family coverage for insurance is $26,000 a year. That breaks my heart every single day. Thank goodness it's largely subsidized. So again, take Medicare out of the equation. Employers are subsidizing the vast majority of this. We're not even talking about copays, deductibles, the actual cost out of your pocket when you go to get a prescription. Just to have insurance for a family in America is now $26,000.
We need to fix that.
Yes.
Mona, I'm kind of curious from your perspective. You've seen models at Humana, now in your current role. You've seen kind of how value-based care has worked in some settings, but fee-for-service is I would say predominantly kind of still leading and in many ways can be a barrier for uptake of value-based care. I'm curious from your perspective, what do you think, or what maybe new payment models do you think could realistically help enable the transition to value-based care? And how maybe is CMS helping or potentially hindering kind of our ability to achieve value-based care?
I mean, I think on the latter question, to what Lee was saying, I think it's not just about whether the models are mandatory or not. I think going into a model, most organizations know that these are 3-year models. And so from an operational perspective, all of the investments that are required to make these things successful long-term, with all your competing priorities, why would you make a heavy investment in a model that is going to be sunsetting in a couple of years? And I think that is something we really have to think about, the sustainability. Oftentimes, when these models come out, the focus is on sort of what do you need to do from a clinical perspective, but I don't think we appreciate the amount of operational investment that is required, and that may be very different depending on the health system and the scale and size of that health system. So I think that actually both colors the results of these models, but I think it also definitely hinders participation or full participation. I think I've been at Highmark for about 1.5 years at this point, and it's been really interesting because I think we are probably the only plan that I know of that went and bought a health system. There are lots of health systems that have started a plan, but I would say that that's fundamentally very different than having a plan that buys a health system, because you're really driving from that identity of the plan and driving value-based care. And so, yes, CMS obviously put forward the hospital at home model, but we have a very robust sniff at home model, right? That's a payment model that we came up with from the insurance side of the house. And the reason that we've had robust participation in it is because we accounted for all of the costs, whether it's the home health aides or all of the staffing, everything that would be required, and then deployed that with our health system partners. And so I think you do need, so many of these conversations end up like a race to the bottom from a rate cut perspective, rather than thinking about what are the outcomes that you're trying to achieve and how can these payment models really help to promote those outcomes. So it has been really interesting to see that collaboration that can happen when you, sure, obviously, the health system also there is fee for service, but you can align incentives across the plan and the health system in these particular models, and they can be successful when you're accounting for sort of all of the costs, and you know that this is going to be sustainable. The other thing I would say is that you know that you're going to have a density of members, right? So for so many plans that might be in a particular market, you might have 10 members in a county. It doesn't quite make sense to make those investments in a particular geography. Highmark, we have a 6-7 million membership. It's concentrated in 4 states. That allows us to do a lot more in these states and in these counties because we have deeper partnerships with our health systems, and it's not just about, again, that race to the bottom. It is about collaborating with health system partners, I think, in a way that you don't see with a lot of plans. Somebody recently said to me, who was CFO of a health system, that she doesn't even know who is really negotiating the rates on the plan side anymore. It used to be that they knew like who the leader was that they could go to as these conversations were happening and think about the joint outcomes that they're trying to achieve. Now it is such a race to the bottom that there's no conversation happening in many cases, in most cases, I would say. So I think that sort of that change in relationship, I think, can be really promoted if you have that density of members and you have this joint stake in those members between the health system and the insurance side.
Yeah, I love that. Sounds like geographic density, I should say, is super critical here in reaching.
By the way,
across
and then I will also say that you don't end up just completely exiting markets like a lot of plans are right now, right? You have to really think about your long-term sustainability in those areas. And we're seeing some of the nationals that are just, completely leaving a lot of counties right now because of the pressures they're facing.
It's a nice segue. I think one of the topics we want to talk about is around outcomes and measuring outcomes, and more importantly, how do you define and really attribute that value? So one of those comments, I think, kind of tie nicely to this. But Lee, I might ask you this question. What do you think are some of the barriers to measuring value, like practically, and any tools or guidelines you think that are most needed to close those gaps?
Yeah, I'm actually going to start with a quote. I get the privilege to working with Mike Levitt, former governor of Utah, former Secretary of Health. And Mike made a comment recently, and he said, he created value-based care, in many ways when he was the secretary, at least from a CMS perspective. And he said, he doesn't even know what it means, but everybody agrees we should get there. And I thought it was a really profound statement in that it's sort of outlining the fact that it's really hard to define. We talk about total cost of care. If you actually ask CMMI, they have 2 authorities, either for certification. One is that you reduce total cost with no change in outcome, or you have an improvement in outcome with no change in costs. Has any model ever been certified for improving outcome? The answer is no. In fact, when I was in the agency, I was supposed to be in charge of certifying for outcomes and, in fact, was never asked about that. So I think, as we said, I don't think this is a critique that HEDIS is what it is. It's really hard to measure health. It's easier to measure total cost of care. So we measure things that we can easily measure, which has been around for decades. And the hard part is the attributable who's attributable for what outcome. And I forget who said this about the patients, because everyone says the individuals themselves make a lot of decisions. If you're in Philadelphia, you can be part of 3 different health systems or 4. You go where you want to go at any time, and we still are like that throughout this country. The hard part is primary. Who do you attribute it? Is it the primary care provider? They would argue that in certain markets, you go to a specialist when you want to go to a specialist, unless you're within a very narrow network. And therefore, when we were at CMS trying to figure out that attributable entity to hold somebody accountable became really hard. You also need a large enough sample size to know, because you have one patient who needs a liver transplant, and that can change the entire cost of care. GLP-1s. I hear your president of Aon talking all the time that it works, but he only analyzed, and I'm going to challenge you if this is correct, the patients who were on it for 2 years. If you were on it for less than 2 years.
I can call him real quick if you want.
What? You could call him?
I can call him.
He actually
on
presented
stage.
this at a meeting, and is that the right way to analyze it? So I think the hard part is we don't have a good system to actually assess outcomes. What I think we do is we assess cost and use some surrogates.
And I apologize, I don't remember the lady's name in the prior session that said this. It does raise the question back to, do people get access to their personal data, and does it move with them? And I think that this does open up the question of how important is that? Because to your point, if employees are accessing a system through insurance, through their employer, but they're nomadic, and we no longer, like, my parents' generation had a job. My generation has 99 jobs throughout their lifetime. So if it's nomadic and we're moving, and an insurer doesn't care or track, well, I shouldn't say care, but they're not going to track after they're off the plan. Who has the data? So now it's like we're starting over, and it just seems like, you know, we're in this, and this is the great thing that this room gets us all for. We're in this age where there is a plethora of data, but how do we connect that data so that the individual can use that over a span of years to get better?
Can I, and I don't mean to be provocative in saying this, but I think if we look, 30 years ago versus now, and we look at the number of measures that are out there that we have to report on, the cost of care has increased at a steady clip in that time period. Access has decreased during that time. Patient satisfaction has decreased during that time. I am not sure that measurement is the way to go. I think basics of patient access and patient satisfaction and total cost of care actually should be sufficient. And I don't know why we don't have that conversation. It feels like we've created an enormous burden on the system without anybody being happy about it. It's not a system that's done well by patients. It's not a system that's done well by the regulators. I just think we have to get back to the basics and have people focus on the things that are really important.
Agree entirely. People call it the quality measurement industrial complex.
Absolutely.
And I was part of it when I was chair of the CSEC at NQF. I actually think, getting back to your comment, that I'm a big believer in patient engagement. There's the Judith Hibbard's work around patient engagement. I think if a clinician writ large can engage a patient to care for themselves better, that's really will lead to better outcomes and potentially lower costs. But we don't measure that.
May I add in here that there's a systemic problem culturally. We do not celebrate healthcare. We don't celebrate taking care of ourselves. We have sick care. Everybody in this room is doing, you all are doing amazing work every day. And you're trying to make a system better, but the system in itself is problematic. We wait until there is a problem and then we go seek care. If more people, so I talked about, the ghost population. If more people, I would argue, and I welcome you all's input on this. If more people were going to the doctor routinely, proactively, how much better off would we be as a society? Would we catch things at stage 1 versus stage 3? Would we never even get to stage 1? These are things that I have to think through with companies every day. And I will give you a personal example, somewhat personal. It's not me, it's his family member. So we have a family member, and I judged him a little bit. So they started taking a GLP-1 for weight loss, and I was like, this is complete vanity. Like, you're only doing this because you just want to drop a quick 40 pounds. You're not overweight. You know what? She did. And 6 to 9 months later, was on a trip with her husband and some friends and found a lump. Full recovery. And then I look back, and I did tell my wife this, I was like, man, shame on me for, kind of judging your sister a little bit on the vanity side of things. Had she not done that, how long would it have taken before she found that lump? What would we have dealt with as a family? We don't know. Thank God we don't have to worry about that. But I just use that, and I'm not here to promote GLP-1s, and I certainly didn't get a text from my CEO saying promote it. But I just, the point is, we're waiting way too long in this country to start caring about what's going on with ourselves. We don't do that to our kids. We take our kids every single year, whenever we need to make sure that they're okay, but why aren't we doing that for ourselves? And I think that we need a culture shift where we need to celebrate the behavior of taking care of ourselves and putting our health first.
Well said. I think what I'm hearing too is the role of the consumer is super critical here as well, in addition to payers, providers, policy like we've talked about so far. And ultimately, if we're trying to get things paid for, reimbursed, it's really important to understand engagement in that model. Then you can understand attribution and value, and maybe decomplex the number of measures that we're actually measuring, and maybe have some impact there too. Nate, I'm curious, coming back to your comments earlier around the health plan, the role of the health plan in kind of driving forward value-based care. What do you think needs to change at health plans? What do they need to do differently to succeed here and empower consumers, providers?
Slightly
to move us
loaded.
forward?
No, I really appreciate, I just really appreciate this panel and the way we're talking about stuff. As we think about value-based care, one of the things that we're really wrestling with is the time horizon of savings. Of like, we want to get paid for preventative care so we don't get to stage 1, but how do you reward in a meaningful way that identification process? And that's something that, like, that time horizon is probably one of the most underestimated detrimental components of the ROI calculation for whether or not we're going to do value-based care and we're going to do preventative care. I mean, it's 10 years at a health plan, and the number of times if I don't get the ROI on this care implementation, this care innovation within 12 months, within 15 months, it's not really worth the ROI. And that's not great for patient outcomes, but it's the reality of a financial organization. And so as I was really lucky in my time at United, especially the last 3 years, to work on a team that was empowered to work really closely with innovative care delivery organization in specific categories, and to design a contract that, yes, we had the horizon of an ROI within 12 months, or that improve outcomes without driving up cost or decrease costs without reducing outcomes. And we were empowered to figure that out category by category: GI, women's health, MSK, diabetes, heart disease, and work with a cross-functional team of a actuarial team, a healthcare economics team, a clinical team, and a network team to kind of put this together and try to do it at scale with different innovative companies. And we'd start in small markets because it's critical to do it in small markets and try to expand it across the country. But I think that empowerment that I had, and I was really lucky to have at the health plan, to say we're going to do really close provider-payer collaboration, and we're going to design payment models for the outcomes we want to see. And we did that better in some categories than others. There's a lot of lessons learned. I had the benefit of working with Shelley at Visana and the work that they were doing in women's health, and how do we really think not just about menopause, but how do we think about the whole woman and all of the health challenges they have on top of going through menopause? How do we think about their journey from menstruation to menopause? And that's a really challenging, under-supported, under-researched journey. And how do we have a payment model that aligns to the care model that they have to support the women that they're caring for? And the same thing was true with Oshi. Of dietary care is terribly reimbursed in this country. Behavioral health care is terribly reimbursed in this country, and it's usually not reimbursed for GI, even though it's a major driver of GI symptoms. And we have all the science to prove that, but health plans don't pay for that. But when we could show that Oshi could decrease the cost of care by 40% by doing conservative evidence-based medicine, taking care of people's diets, doing high-touch care, having 24/7 care available to reduce the #1 reason for treat and release in the ER, like we could tie our payment model not to the utilization, but we could tie it to the care that was being delivered as a journey and as an episode, and tie that to the predictable reduction in utilization of other unnecessary, very expensive services. And so that having a brilliant team that I had the honor to coordinate, I wouldn't say I led at all, coordinate a team, a cross-functional team who was empowered to design these things, was one of the most fun jobs I've ever had. And now I get to do that on the other side, where I work with health plans, and it's that the deciding of success that I have with the health plan is, do they have a team who is empowered to not just do what we've always done and do fee for service, but they're empowered to say, what is the right way to pay for the outcomes that we're trying to accomplish?
Well said. I'd love to get Mona's perspectives here too.
Quick, because I know we're almost at time. I just want to underscore the 1 year piece that I don't know how many folks have done pilot programs with health plans here. A show of hands, anyone? So you've lived to tell the tale. But I want to just make sure folks understand what that means. It means if you have an MSK solution that's going to prevent somebody from having a fall, you come to a health plan and you say, I'm going to be able to come in and I'm going to give you a 2-to-1 ROI. That means for every dollar I spend, you're going to give me savings. And I'm going to be able to generate that for you in a year. Because then from a health plan perspective that is supposed to be making money, you are then baking that into your projections. That means that you have to, that MSK vendor is going to have to come in and they're going to have a commitment to enroll 2,000 patients, because if they don't enroll and engage and have those 2,000 patients follow through on that entire program, I won't have enough of a sample size to actuarially see that there's any impact on total cost of care. So if they can't enroll enough patients, if they can't sustain engagement, or if they just don't demonstrate any savings in either one of those scenarios, within 1 year, then we're not going to be able to partner. And now we're asking, many plans are asking these companies to say, okay, well, if you're not achieving these outcomes, then you put your fees at risk. Otherwise, we're not going to partner, because the dollars that we're spending, here means that we're not spending it at someplace else. And right now, we're just trying to get to 2% margins, right? It's basically what plans are saying, 2 to 3% margin recovery. So whereas 5-6 years ago, everybody was going and doing a lot of pilots. Now everyone is thinking twice about it. There's a lot of sort of financial constraints. We want to still do those pilots, but we want to have some guarantee or some understanding of the results that folks have had in the past that demonstrate those savings moving forward. So it is, the dynamic has certainly shifted. I think it's you can still have a very healthy, productive partnership, but it just involves being a lot more transparent around data and what you can actually do from a patient engagement perspective as well. So anyway, I don't want to paint a gloomy picture, but I've seen a lot of people and dollars wasted because folks haven't had transparent conversations up front that need to happen up front.
Can I add one thing to that? And I'll be super fast. To build off that ROI story, easy, repeatable, trustworthy analytics propensity matching models to verify that ROI.
RCTs.
Really, we would love to do RCTs.
Propensity matching would be like second tier, like
Yeah.
you really want to see an RCT,
do
which
this with
again,
propensity
you can
matching.
imagine how
Yeah,
difficult
well,
that is.
RCT is the gold standard. It's just not possible in a lot of categories. Really expensive, hard to get sample size. Propensity matching is definitely, it's number 2 on the list. But having easy, repeatable, trustworthy models that are scalable, that are adaptable to different categories, that are predictable, I think that's something that's really missing in validating these innovation solutions. And like we tacked one of those on to every single offering we implemented. And we turned off some contracts because they didn't create value, but we found others that were creating amazing value. So it's just that model is it's administratively burdensome, and so finding really good, trustworthy, and predictable ones. So I don't know if you have something you can add to that.
No, I was just, no. I know, we're out of time.
We're out of time. We didn't even get to cover AI or unpack more of these questions.
Can I say one thing about
Please.
AI? I keep hearing AI
will
today.
cover
We're
AI.
here at time. And interoperability is key. I happen to think multivariate template matching, which I can explain afterwards. But the key thing we have to acknowledge is people don't know how to use the information that we're getting all this data. We need to actually teach ourselves and the clinicians who care for us, and I mean clinicians writ large, how to use it in a Bayesian framework, or we're going to be in a much worse shape than we are today. I'm sorry, but that's how
I just don't hear Bayesian enough in my life.
I'm a Bayesian.
I think we're at time, but that's actually a great segue because I think later in the afternoon there'll be a topic to go deeper in how do we actually do the things that we talked about today and some real action items coming from that conversation. So I'll encourage you all to bring your best thinking to that session here as well. And with that, I think a round of applause for our panelists.